if anyone of you has any question, you please write it or raise your hand, they'll give you the mic. So the first question is by Dr. Syed Aliruh for Dr. Javed Malik. The question is that what kind of immunotherapy should be given in renal tubular acidosis and interstitial nephritis due to Sjogren's? And are these two complications more common in primary or secondary Sjogren's?
Thank you. Primarily, the thing is that interstitial nephritis, I would seek the help of the nephrologist colleague here, and if they want to do if they have done a biopsy or so on. But certainly for renal tubular acidosis, you would just treat and keep an eye on their potassiums and monitor their serum potassium, give them advice about diet, and so on. There is no, to my knowledge, any data or the use or the benefit of using immunotherapy in this, at least in my sort of limited study that I did while I was preparing for this talk, very little data in terms of treating. Certainly if there is glomerulonephritis or there are other like vasculitis and so on, then rituximab may be an option there.
Thank you. The next question is for Dr. Daniel. If a patient on tofacitinib develops leukopenia and absolute neutrophil count less than 1,000, should you stop the drug? And at what level ANC comes normal, would you like to reintroduce it, or you will never reintroduce it?
Yeah, I would say you would stop the drug. There are guidelines that are published. What references do you use, anyone in the audience, to look up the answer to that question? Do you have a reference that you prefer to use?
1500.
What's it called?
1500, 1.5.
Oh yeah, the number for the white count?
Yes.
Yeah, but like if you don't know the answer to the question, what reference do you have available to you? Like a clinical decision support reference? Up to date or something like that?
Yeah,
up to date. Because you know, that type of question asked by the audience member is, you could repeat that in, not that same question, but there are many questions like that. I use up to date a lot. It's really hard to remember all these things in the top of your head. You know, sometimes it's helpful to use a CDS tool like up to date. But yeah, I would stop that. I would stop the drug. I would wait and see if that neutrophil count rebounded, and if it rebounded back to to the levels where it was at before, I would reintroduce the drug. And that's with a patient who can get to the lab and be compliant with follow-up.
So while you are on the rostrum, Dr. Sagar,
Thank you.
Can I ask him another question? So thanks for sharing your experience, and I would also share my little experience. I agree that the landscape is changing with the arrival of tofacitinib in Pakistan. My experience also was that I relied a lot on oral DMARDs, and then switched to anti-TNFs, and then the IL-6 and rituximab in that order. As the guidelines have changed, we have switched from triple therapy to monotherapies, and then we add them accordingly according to disease severity. But as you know, in Pakistan, access to biologics is difficult, and you alluded to that earlier. So my experience in sharing is that since adding the tofacitinib to the armamentarium, the reliance on, in my experience, anti-TNFs has decreased. And my success rate, and I did raise my hand, I do have more than 30 patients at this time with rheumatoid arthritis and psoriatic arthritis. And I would say success rate is between 80 and 90%. In my patients, I have not seen herpes zoster and no malignancies. Recently, before I came for this, I did got one message, a patient developing some erythema nodosum-like rash, and I have to investigate that, some back pain if it's kidney involvement. But I would say that I do rely on methotrexate a lot plus tofacitinib. My question is if you can share your experience in regard to tofacitinib, as you were alluding to the 68-year-old patient with multiple drugs and back and forth with the anti-TNF and IL-6. What would you say, can you say that having used, because you do have 15 patients, and can you say at this point that have their disease in terms of radiological markers like erosions has progressed, or you cannot yet comment on it?
Yeah, I don't have that data to show in terms of X-ray progression or even laboratory test profiles on individual patients. That would be a nice next slide to show if I had had the chance to put that together, but I don't have that data. I think the clinical trials data really is important because our individual experiences are individual, and it's where you blur many, many thousands of experiences together that you can sort of tease out those types of answers to your question. I think it's difficult to do that in a talk like this one.
There's another question for you. Okay. That what is your experience with other JAK inhibitors? Like
Yeah, I have probably 2 patients on an alternative JAK inhibitor because Xeljanz, the brand name Xeljanz, which is tofacitinib, has been on the market for 5 years now in the US, 6 years, maybe even longer, whereas the alternatives are more recent. You know, when Enbrel came out in 1997, it was such a revolutionary drug in my own personal practice that when the others started to come, I would tell patients, they'd come in and they'd say, well, I heard about something on television. I'd say, you know, you could take that if you want, but you know, one is Coke and one is Pepsi almost, and if Coke works, why go to Pepsi? Except for marketing. And there's some truth to that and some truth to the opposite, but yeah, right now I am not preferentially using the newer JAK inhibitors because there is no data that says I should. And so I feel like it's Coke and Pepsi right now on those 2. I mean, there's some nuance and some spin, but you know, yeah.
Thank you. Thank you so much. Do we have any more questions
Yes.
from the audience? Yes. There's another question from the audience.
So my question is from Dr. Beena Hamid. Actually, we come across with a few females who are in the fertility age and have been started on leflunomide by some other physicians, and they come to a rheumatologist, and they just have started with the leflunomide for a couple of weeks or months. So is there any specific duration where we do not need to have leflunomide washout?
It's difficult to say. I'm not aware of any studies advising on how long the patient
Because
would have had.
there are few patients who have started 2 weeks or sometimes 1 month before they visit to a
Maybe I should ask this
rheumatologist.
question from Dr. Terry Gibson. He is the most experienced rheumatologist among us. But I'm not aware of any data.
And the other is, the most important, we do not have the trough level of leflunomide available here in Pakistan. So after washout of leflunomide, can we proceed further?
You just do a level. You don't have to do a peak cutoff because when you wash out, you have actually stopped the drug, which essentially means whenever you do, you get the true level. So the guidance is if it's still above 0.02, then you give another washout.
It's not available actually here in Pakistan.
I know it's difficult, but this
Thank
is
you.
what it is.
Thank you. There's another question from the audience.
I have 2 questions. First, Dr. Kitolo, you know, you have taught us a new aspect which we had totally forgotten. An excellent workshop yesterday. Everybody learned so much from the exercise yesterday. Can you hear me?
Yes.
Yes. So fantastic talk today as well.
Can hear you.
Yeah. So I have a question. What is your experience of using JAK inhibitors in patients with ILD and scleroderma? Do you have
To use what, sorry?
JAK inhibitors in ILD
Okay.
for scleroderma?
No. Yeah. Personally, and in our group, in my department, we don't have yet experience. But I can tell you that if we move to the concept of the tyrosine kinase inhibitors, we have the experience with the nintedanib, that is exactly a tyrosine kinase inhibitor. And we also were participant to the first study for the registration of nintedanib 5 years ago. And the results, as you know, were published in New England Journal of Medicine and seems really a real advantage with improvement of the lung functionality at any level. So this is just an example how using drugs that works inside the cells, because the kinase inhibitor enter the cell, do not block outside mediator like cytokines or on surface mediators like rituximab, CD20, CD19, or CD80, CD86 for abatacept, but entering, blocking the intra-signaling in the cells works, and probably the cells with high turnover, like fibrocytes, fibroblasts, responsible for the fibrosis, are very sensitive, in particular, to the tyrosine kinase inhibitor. So our experience is limited by now to the nintedanib and was really positive.
Thank you so much. One more question, and that is from Dan. As we have decided in life that we are going to make our patients partners in decision making. So whenever I see somebody who is young, is less than 65 years of age, has no history or no contraindication to giving tofacitinib, and especially in the middle age and young people, and when I give them the options, they choose JAK inhibitors because it is easy for them to carry those pills. They don't want injections. I think we should do this survey in our people. What do they prefer? They prefer pills. So what I was trying to say that I know the guidelines are different, but if the patient preference comes first, then are we supposed to alter that guideline and go straight to JAK inhibitors?
Yeah, no, it's a good point. It was one of your main points that the younger you are, the safer the exposure. Maybe, I'm not sure about the pregnancy issues with the JAK inhibitors. Oh, sorry? Yeah. Yeah. Yep.
So the guidance up till now that I'm aware of is that they shouldn't be on JAK inhibitors.
Should not,
Yeah,
yeah.
exactly.
Yeah, that was my understanding too. And I think, because it's always like the young person, that's the easier person, not always, but often the easier, less complicated, fewer comorbidities, and then oral drug on top of that appeals,
Yeah.
So, but then there's the pregnancy thing that
Yes.
sneaks in there.
But I think because it's such a short half-life, so you can stop maybe 1 to 3 months in recommended
Right.
before you conceive. So probably it's okay to give them, but then obviously when planning pregnancy, you stop in well in advance.
Yeah.
I have a few questions, one question for each speaker. So I'm going to start with Professor Cutolo. Excellent, wonderful presentation. We learned so much. I just want to know what has your experience been with the combination of drugs used for established pulmonary hypertension? Because that is one thing we see a lot in our young girls here, and I find that is sometimes harder to treat than is interstitial lung disease and all.
Yes, thank you for your question. As you know, it's from some years that the concept of combination therapy, double, triple combination therapy, it's the most suggested because it's clear that if you think about my today presentation, the final clinical results in systemic sclerosis regarding the lung, you asked for the lung, that is the interstitial lung disease and pulmonary arterial hypertension, is just the progression of this initial vascular damage, loss of vascularity, and increase the progression of fibrosis from the other hands. In other words, the blood flow find a wall with a lot of fibrosis and less vessels. So the approach that is suggested is always when you are in front of an autoimmune disease to use immunosuppression in any case, because it's an autoimmune rheumatic disease or autoimmune disease, don't forget. So which is the best experience in our hands is as immunosuppressor, as a systemic sclerosis like other autoimmune disease driven mainly by B cells and autoantibody is to use rituximab. And there are several recent study, but also old study that say, don't forget immunosuppression, use rituximab. First. Second, vasodilation. It's really important for several reasons. One of the reasons is that you can still act on the vessel when you contemporarily give a drug that you want as a target the cells of the immune system in the lung, for example, and you induce in the same time vasodilation, the penetration of the drug is much better. And at the same time, vasodilation induces an increased oxygenation and possibly vascularization, neoangiogenesis. And a third level is to try to use drugs that in some way may reduce the progression of fibrosis. And here, from the experimental model, from in vivo and from clinical data, once again, nintedanib has been shown that may reduce the fibroblast progression to the myofibroblast, in other words, to the fibrosis. So at least three important components in the progression of the fibrosis. There are immunosuppression, vasodilation, and if possible, and now probably we have some drug, reduce the fibrosis, really improve, reduce the progression, and we have, but also published in many other studies, that when you improve such kind of progression, reduce the progression, even the capillaroscopy is related to the pulmonary hypertension progression or to the interstitial lung disease. There is a negative correlation. Less loss of vessels, less fibrosis, less decrease on the pulmonary function.
Thank you so much. Is there a specific drug that you use for, suppressing fibrosis in the setting of pulmonary hypertension? Any particular?
Indeed.
Yes.
Well, here is interesting to consider the experience your colleague mentioned about methotrexate, because methotrexate is a classical anti-proliferative drug that we mutated from oncology because it's able to reduce the proliferation of the cells. So we reduce the proliferation of immune cells, but also the proliferation of fibroblasts. So in some way, if you don't have the possibility to use very expensive and sophisticated drugs, and I would include also mycophenolate as an anti-proliferative drug that is very effective in progression and reducing the progression of fibrosis. If you have in your country, can use. Mycophenolate today is considered one of the very advantageous drug in such kind of combination with immunosuppression, vasodilation, and tentative to reduce the proliferation of the cells involved, and particularly fibroblasts.
Professor Cutolo, thank you so much. As Chair Scientific Committee of this conference, thank you for your generous time and wonderful expertise. I have two brief questions. One was from Dr. Shakeb on if he's had any experience of mycophenolate. Okay, and the second is Suleiman. I want to know if you've used, what has been your experience with using methotrexate in Takayasu. And I just want to, I don't know if we have time, so I just want to say fabulous, fantastic presentations, Bean and Dan. I took lots of pictures. So your experience of using methotrexate in Takayasu.
I personally have used it along with steroids with reasonable sort of response, but if it is not working well, then obviously TNF will be the way forward. I had one patient and she was not really so well, so This was just prior to the ACR guidelines, and I actually started her on tocilizumab, and she responded well to that. So I'm just thinking whether I did the right thing or not, but you know, it varies from patient to patient. And really, if methotrexate is not working, obviously we just switched over to other immunosuppression.
Thank you. One last question from Javed. I think in the introduction, the one very important thing that we have not mentioned about Dr. Javed Malik, he's one of the founding PSR members. He's a past president. He is our constitutional head because he knows the PSR constitution like nobody else. And he is the most fantastic colleague and support and friend for all of us through the years.
Thank you so much.
I have to say that, yeah. So, Javed, I think one thing we all have are our patients with Sjogren's are always unhappy with their Zika symptoms. You know, whatever you do, what is really bothering them is the dry eye, dry mouth. That's so. In your experience, what do you think has helped? I know there are case studies on rituximab, on hydroxychloroquine helps, but other than supplementation of tears and saliva.
As far as the clinical trials go, the results were not helpful, but certainly subjectively, oral stimulants have a role in. We don't have that easily available in our country, but certainly topical artificial saliva is available. It's still very expensive. The cost is more expensive than JAK1 inhibitor if you compare it to per month cost. So then you're left to our devices, educating them and avoiding dehydration and something in the mouth, sipping lemon water and so on. So those kind of things. But the point you highlighted extremely, it's been noted, reported, the health-related quality of life, because these are chronic symptoms, they're not going to go away. And so far we have nothing which can cure their Zika symptoms. So it is a very important quality of life issue, and it always remains a challenge.
Thank you. Thank you. Now this brings us to the conclusion of this last session. I would request our chair, Dr. Takdees Khalik, to just give a brief verse about the talks, and then we'll start the shield distribution. Dr. Takdees, you can come here and give.
Thank you very much, Dr. Bilal. I would like to begin by congratulating Dr. Saira, Dr. Bilal, and their team for this spectacular conference. It is always a pleasure to attend PSR meetings because the quality of content is always amazing, and this particular session was no exception. The first talk by Professor Cutolo was very informative, very elaborate, and it has made us look at Raynaud's from a very different angle. I was also fortunate enough to attend the capillaroscopy workshop that he organized day before yesterday, and I think I can vouch that he's a master in his field. It was a pleasure to be attending that workshop. The second talk of the session by Dr. Shakib was also very helpful. It is always a delight to listen to him. The way he passionately shares the stories of his patients with us makes it very easy for the audience to sort of connect with what he's trying to say. Today's talk was also brilliant. The third talk of the session by Dr. Javed was also very enlightening in the sense that it sort of prompted us to look at Sjogren patients beyond Zika symptoms. We tend to sort of confine ourselves to Zika symptoms and fatigue only, but all said and done, it is a multi-system, it is a disease that can have multi-system involvement, and we should actively look for that. Fourth talk of the session was by Dr. Bina Hamid, and as always, it was very crisp, very to the point, and very helpful, very pertinent and relevant to what we see in our day-to-day practice. There were lots of take-home messages, especially for our junior colleagues, so thank you very much for that. And lastly, the talk by Dr. Daniel was also very helpful, very enlightening, particularly because tofacitinib is sort of new in Pakistan. It's been launched here only like a year ago, so we don't have local data. It was very kind of you to share your experience with us. It will definitely increase our confidence in the drug and pave a way forward in the management of patients with inflammatory arthritis. The question answer session was equally enlightening. We had a very good discussion, and overall, this whole session was very wholesome. Thank you very much.
Thank you so much. Thank you so much. Now I would request our chair, Dr. Takdees, to please give the shields to the speakers. Professor Cutiolo, you're not here. Otherwise, we would have presented you with a shield. We have a shield made for you.
Thank you.
So we'll give the shield next to Dr. Javed Malik. I'll also request Professor Nighat Mir and Professor Sumaira Farman to come for giving the shield to the speakers. Thank you. Next, I'll request Dr. Beena Hamid to please come and take your shield. And now I'll request Dr. Daniel Sager to please come and take his shield. Thank you, everyone. Yes, I'll request Dr. Ahmed. Thank you. It was nice having you here. Now I'll request Professor Nighat Mir, Professor Sumaira Farman, Professor Ahmed Saeed, and Dr. Saira Khan to give the shield to Dr. Takdees, our chair for the session. What certificate? Thank you. So this concludes our session. We are especially thankful to Professor Cutiolo for being here. Professor Cutiolo, thank you. So we have ended our day. This was the end of our first day of the Silver Jubilee Pakistan Society for Rheumatology International Conference. So we have inaugural ceremony here at 7:30 p.m. After that, there would be a dinner. And next morning, we'll meet again here at 8:30 a.m. for the next session. Thank you. Thank you, Professor Cutiolo. See you. Bye.
Thank you to all of you and my best wishes for the next days. Enjoy your Silver Jubilee.
Thank you. Thank you. Thank you so much.